I'm Doug Drachman. I'm an interventional cardiologist at Mass General Hospital in Boston, Massachusetts. And this year, I am the chair of the annual scientific session for the American College of Cardiology. The excitement in the air has been absolutely palpable. I think people have been really energized, not only to reconnect with friends and colleagues, but also to explore the latest science. We received about 15 to 20% more abstracts this year. Those are the submissions of science that we consider for presentation in poster sessions and moderated sessions, as well as in our late-breaking clinical trials, which is where the very last minute science gets presented. I'm an interventional cardiologist, and so I naturally gravitate towards the science that is being presented that's within my specific area of expertise. And there are a couple that I think will stand out and we'll have to discuss and think about a lot in the weeks to come. One of them is called the Danger Shock Trial. That's a study that looked at patients who come into the hospital in the context of an acute heart attack who have very low blood pressure because of cardiogenic shock. And there is a device called a microaxial flow pump that helps to support the heart and support the blood flow in patients who are in an extremely unwell circumstance. And what the study showed was that the use of this pump for individuals having an acute heart attack can help to save lives over the first 30 days. And specifically, it allows time for patients to recover and to undergo treatments to open up blocked arteries in these cases of acute heart attack. That was one study that I think has the opportunity to change our practice, although, of course, these are abstracts being presented at a scientific session, and we'll see how it permeates into the real world as we really live this. Second is a study that's entitled the Ultimate DAPT Trial. DAPT stands for specific medication choices we might make with so-called dual antiplatelet therapy. So when individuals come into the hospital with a heart attack and need a stent to open up the blocked heart artery, we very oftentimes use two medicines to thin the blood to protect this wire mesh prosthesis that we insert into the artery of the heart. And what happens when you use two blood thinners is it can lead to higher risks of bleeding. But that has been our paradigm for the past 25 some odd years, is to use these two medicines, even if there is some risk of bleeding. This is a study that may now shift our paradigm. It suggests that if we use both medicines for only 1 month and then revert to only one of these medicines, the more potent, what we call platelet blocking medicine, in the trade name or the generic name of this is ticagrelor, but these are medicines that can help to keep the stent open. And if we reduce it to just one medicine, we can reduce the risk of bleeding, but still have the same protective benefit for the stent. So this may really change our paradigm in how we treat patients coming in with acute heart attack when they receive a stent, and hopefully help to reduce risk of bleeding, which can have other adverse consequences down the road. One other study that is totally hot off the press is something called the PREVENT trial. The whole idea is that when we deal with patients who have a cholesterol plaque narrowing in an artery, there have been studies over the past 20 some odd years that have told us, believe it or not, that it's not advisable just to put a stent in an artery because there's a narrowing. It doesn't tend, at least in our historical experience, to prevent or stave off a heart attack. This is different when someone comes to the hospital with a heart attack, where we know a stent can be life-saving. But for people who are walking around with a narrowing, we don't believe that the stent would necessarily thwart a heart attack. These investigators, however, looked very carefully at the types of plaque that people might have and explored them to look for what we call vulnerability, or some characteristics that may increase the risk that these plaques could become active and lead to a heart attack in the future. In those specific circumstances, it may be additionally protective to consider using a stent as opposed to medicines alone. So this also has an opportunity to change our perspective and our practice, but I do believe that this warrants a lot more investigation moving forward, a lot of discussion before it is that we start to do things differently.
Good morning. I'm Mikhail Kosubarit. I'm a cardiologist at St. Luke's Mid-America Heart Institute and Vice President for Research at St. Luke's Health System in Kansas City. You and many others know heart failure is a huge problem. The prevalence of heart failure is rising. Millions of people have it, both in the US and globally. And what we've noticed in terms of epidemiologic trends over the past couple of decades is there is one particular type of heart failure that has been really increasing dramatically, over the past, 20 years or so. And that's a type of heart failure we call heart failure with preserved ejection fraction. And obesity is very common in people with this type of heart failure. In the US, about 80% of patients that have this type of heart failure are living with overweight or obesity. And so the whole concept behind this trial, and actually it's a trial program, which I will mention in a minute, maybe obesity is what's actually causing the heart failure. And that's why the rates of this type of heart failure have been going up so much. And then, of course, the next question, if that's the concept, right, that you are thinking through, then the next question you want to ask, well, what happens if we actually target obesity with anti-obesity medications? Will it improve the heart failure? Will it make patients feel better, be able to do more, and improve heart failure outcomes? So the STEP-HFpEF program actually has two trials in it. The trial called STEP-HFpEF, which we presented at the European Society of Cardiology last year in August and published in the New England Journal of Medicine. And then what this at least indirectly suggests is that semaglutide and its benefits in this type of heart failure are likely not all related simply to weight loss. There are probably other effects of the medications that go well beyond weight loss. And you're looking at other outcomes that we observed in the study. So we saw, again, improvement in exercise function, we saw reduction in inflammation, and we also saw a significant reduction in a biomarker of congestion. And congestion is ultimately elevation in pressures inside the heart. That's what causes the heart failure symptoms. And that's really suggests that semaglutide is truly disease-modifying treatment. It actually, modifies or improves the pathobiology of the disease process itself. So it's not simply that people lose weight and feel better. It really seems to change the underlying pathobiology of the disease.